So for the severe features, you must come to a hospital as soon as possible. And for this kind of severe features, then you have to uh, stop, try to maintain the pregnancy. You should just delivery. So if like we said before, the blood pressure cannot be controlled, or the headache cannot be controlled, or her epigastric pain is just more severe, and all other things like stroke, myocardial infarction, and HELP syndrome, or your renal function is already worsening now, or you have dyspnea because of pulmonary edema, or you already have the eclamptic attack, or like we always know, like if you have bleeding, then it might be a acute placental abruption. All these things are suggesting that we should deliver the baby. And for the baby, of course, if you have a abnormal fetal testing, like a non-stress test is not reactive, or you have already a deceleration of fetal heartbeats, or inside the baby already have a IUFD, then there's no reason why we should keep the pregnancy. Or otherwise, like we have like what we said before, the umbilical artery already presenting the IDV or ADV, then the abnormal umbilical cord flow, then we suggest the patient to have just delivery, because if the baby just keep inside the belly, then it's just not safe. So even if the baby is still very extreme preterm, like 24 weeks or 28 weeks, we still have to let the baby out to save the baby and also save the mother. So the recommendation for timing of delivery, if the patient is just a chronic hypertension, they don't have the preeclampsia severe feature, then we can let them delivery after 37 weeks. And if it's only gestational hypertension and they don't have severe features, they can also over 37 weeks to do the delivery. But if for a patient is already have a preeclampsia before 34 weeks, then after the magnesium sulfate or other things that we think is not possible to keep a pregnancy, we should just delivery. And for 34 to 37 weeks, because it's still preterm, but the baby is actually mature enough to take the risk. So for this interval, we still suggest that you just delivery. If the patient or the baby have already have some severe features. So delivery is the only method to cure the preeclampsia and the eclampsia. But because maybe the gestational weeks is very remote from term, so if we can use the magnesium sulfate for seizure prevention, if we can stabilize the patients, and like for now we have 48 hours timing that we think the patient won't develop to eclampsia very soon, then we can give the baby corticosteroid for fetal lung maturation. In our hospital, we use betamethasone 12 milligram, 24 hours apart before 34 weeks of gestation. But here we can see from this table, if the gestation is above 37 weeks, then we just delivery. But if it's not, then we have to see the gestational weeks. Okay, so if the gestational week is even more than 20 weeks, we just maybe it's other disease. But if it's before 24 weeks, then we can just terminate pregnancy, because if we don't let the baby out, even if it's preterm, very preterm, maybe it cannot survive, but we still have to save the mother. So if it's before 24 weeks and the patient already have a severe eclampsia or other severe features, or it's very emergent, like she already cannot breathe, or she already have a heart attack, then we still have to terminate pregnancy to save the mother. And if it's above 24 weeks and we still all the severe feature comes, then we just deliver a baby. Okay, and it's above 34 weeks and we don't think so much, we just deliver a baby. So the answer is the delivery. And now we will talk about the HELP syndrome. Like we said before, this hemolysis, elevated liver enzyme, and the platelets. So if we use the ECOG criteria, then we can use the LDH more than 600. And we can use the AST or ALT for the liver enzyme to see if they are elevated more than twice the upper limit. Or we can use the platelet count that is less than 100,000. Then we can use this hemolysis, thrombocytopenia, elevated liver enzyme, and ECOG criteria as a HELP syndrome detection. And also we can use the Tennessee classification or the Mississippi system. They're all the same, but it's just different in the numbers. So like in Mississippi, they have a class 1 that is more severe one. The platelet is less than 50,000, and the class 2 and class 3 is a mild form. Okay, and the Tennessee system is also like this. So each way you like, but just remember if it's not good, like LDH is already over 600, like liver function is already high, and cytopenia already occurs. You don't really need to have the time to classify, like it's class 1, 2, or 3. Maybe you just think about the magnesium sulfate to stabilize the patient, and then you just go to the delivery. So the symptoms of HELP syndrome is still like the severe features of preeclampsia, like headache, like nausea, vomiting, like upper abdominal pain, which is the liver function deterioration, and also the shoulder pain or the breathing difficulty, and you have vaginal bleeding, or you have a change in vision that you can see things clearly, or you have a general edema. All these symptoms are HELP syndrome. So it's just like our severe features before. Okay, it develops in all pregnancy about 0.2 to 0.3 percentage. And for preeclampsia, it's more common, but HELP syndrome can also develop in preeclampsia groups. And
Okay.
superimposed HELP syndrome develops in 4 to 12% of women with preeclampsia or eclampsia groups. So when our patient have a preeclampsia with severe feature, like we know they maybe have a liver function disease, and they can have a thrombocytopenia. So the preeclampsia severe feature and the HELP syndrome, sometimes they're combined together. Okay, and when you have HELP syndrome, mortality is very high. It's up to 24%, and the perinatal mortality is up to 39%. Okay, now the interesting about the thrombocytopenia, about the preeclampsia and the HELP syndrome, it's like they have something interesting. We have to differentiate them from the FLP, HUS, TTP from and HELP syndrome. All these diseases, this green circle here, we have a thrombotic microangiopathy. It's like we can find out their blood cell is likely the Helm syndrome. Um, but in HELP syndrome and preeclampsia, thrombocytopenia, they can also have Achilles syndrome. An interesting part is that some of the HELP syndrome patients, they do not have proteinuria, and sometimes they even do not have hypertension. It's a very interesting part. So as what we know before, the HELP syndrome, the diagnosis HELP syndrome is hemolysis, elevated liver enzyme, low platelets. In this syndrome, they don't have a definition for hypertension. Like we said before, for preeclampsia, we need to have the blood pressure and proteinuria or severe feature. But in HELP syndrome, you only have to have hemolysis, elevated liver enzyme, low platelet. You don't need to have hypertension. So when your pregnant woman come to your hospital with already HELP syndrome, you don't need to argue with other staff like she doesn't have hypertension, she is not preeclampsia, she doesn't do any analysis. That is super wrong because in HELP syndrome, you can always have a hypertension patient, non-hypertension patient. So when you have a HELP syndrome like hemolysis, elevated liver enzyme, low platelet, and the patient does not have a proteinuria, the patient do not have a hypertension, you still have to think it as a very severe form of HELP syndrome and just do the magnesium sulfate and just do the delivery. And for about acute fatty liver syndrome, HUS and TTP, they can develop a thrombotic microangiopathy. So sometimes it's very confusing and it's very difficult. That is, you can also have all the symptoms mixed together. So how do we define is a preeclampsia is HELP, is a TTP, is HUS, or is a FLP? Does it matter? Of course it matters because if it's a HELP or it's a FLP, we have to do a delivery and also we have to give the magnesium sulfate. But if it's for HUS, you have to think about consular kidney doctors because it is more like a kidney disease. And for the thrombocytopenia, is a neurologic signs, and maybe you have to do a plasma exchange. So it's very difficult. Actually, it's always confusing when a patient come to a clinic and have all these things mixed together. But I think it's supposedly we still have to remember that we just stabilize the patient, that we still give them magnesium sulfate, and we do all the checkup to see which kind is more likely, like preeclampsia is more likely or TTP is more likely. But overall, in pregnancy, HELP syndrome and preeclampsia is more common than the other three symptoms. Okay, so the management here, we can see you have to do lab testing because you have to have the platelet count, you have to have the liver count and LDH count to know if you do have a HELP syndrome. So remember to check the CBC, LDH, liver enzyme, and kidney enzyme, and all the other biomarkers like a potassium or calcium, other things. We will have a group set of laboratory testing already set together to do all the testing. And after all the testing comes out, then we can know if it's a HELP syndrome or it's just a preeclampsia with severe feature. So, now we know it's a HELP syndrome, then we can think if the patient is stable, then we can send them to do the fetal assessment or to do ultrasound. But if the patient is not stable, we have to stabilize the patient first. We give them IV, we give them blood components like a platelet, or we give them magnesium sulfate to prevent the seizure attack. And if the baby is still remote from term, then we give them corticosteroid for fetal lung maturation. And also in this kind of patient, if they do have hypertension, then we still have to give them antihypertensive agents. And if the patient is stabilized, then we can do the second thing is to test the fetal if it's good and to see the ultrasound to see if other things inside. But if everything gets deteriorates, like the patient is confusing, the CNC system is just breaking down, then we have to deliver as soon as possible despite of the gestational ages. Okay, now we already mentioned a lot of times before the seizure prevention. We use the magnesium sulfate. If any one of you is not a obstetrician and not specialized in obstetrics, you might wondering we do have other medication like can control the seizure like phenytoin or like Artivan, like we can control the seizure. Why do we just use magnesium sulfate? Because this is the best one because it can stabilize the neural system and it can block the NMDA receptor. So it's magnesium sulfate is the medication of choice. And you can also to have a tocolysis and you can also protect the fetal's neural function. As all we know, we use the magnesium sulfate as a neural protection in preterm babies. So in seizure prevention, you don't need to overthink. We just give them magnesium sulfate. So the loading dose is 4 gram, and we use continuous dose at every hour 1 gram, and we had keep the magnesium sulfate postpartum for 24 hours. And if you found out that patient is more severe, like you already have a cerebral hemorrhage, if you think the eclamptic status is very severe, like you cannot just control for 24 hours, you can just make it longer like it's 48 hours or even 72 hours. It depends on the patient status and the disease progression. Do we need to postpone use of magnesium sulfate? It depends on the clinical situation. But normally, remember if the patient is not so severe, you just do the prevention. Remember to keep it till 24 hours postpartum. And during we use the magnesium sulfate, we have to remember it's also toxic. So when it's above the treatment level, it could become toxic to the mother. So we have to observe the DTR and other informations. I'll show you later. And when we already have the toxicity, then we have to use calcium gluconate to solve the magnesium sulfate overdose. Okay, it's like here. So the treatment dose is about 4 to 8 milligram per deciliter. So it's shown here. It depends on which kind of measurement you use, like this or this, and the treatment level is around this. Okay, so when it's over the treatment level, then we can have a loss of DTR, we can have a respiratory paralysis, and the more severe form, we can have a cardiac arrest. So when you use the magnesium sulfate to do the seizure prevention, make sure like you understand this can also be a toxic. So it's also a cure, but it's also a toxic thing to your body. So we have to measure our magnesium level when we use the magnesium sulfate. So remember the urine output has to be more than 30 milliliter per hour. The respiratory rate has to be more than 12 times every minute. So, and you should have a DTR. And DTR will be the first thing to lose. So you can check the DTR every 8 hours when your patient is using magnesium sulfate. Okay, so when the toxicity comes, then we have to stop medication. We have just stopped the IV of magnesium sulfate, and we should obtain the magnesium level from the patient immediately. And when the level is come to regular and the patient is okay, she doesn't seem to like have a toxicity now, then we can restart or reduce the dosage. And remember, if your patient already have a renal disease, like she already have a renal function impairment because of preeclampsia or because of a previous disease, then the magnesium sulfate level should be lower. Like you cannot use program immediately. You have to adjust it according to the patient's renal function. Okay, so when the respiratory compromise, you have to give them the calcium gluconate for 1 gram, and maybe you have to do an intubate and assisted ventilation. It might be necessary. So for the when the patient, when we do all the work before we do the blood pressure control, we do the aspirin population, or maybe the patient didn't have the aspirin population, and you just come to your hospital in the emergency room or in your obstetric wards with eclampsia attack. First thing is to protect the mother, so stabilize the patient, make the patient safe. Do not put anything in their mouth. Do not restrain them. You just let the seizure go away, and remember to do all these protections in like all the eclamptic attack. And so we protect the mother, protect the airway, and then we must give them magnesium sulfate immediately. So maybe sometimes um, you will have the situation that is very severe, like the patient have a seizure attack and it's just not in the ward or in the ER yet, or it's in your ward, but she already have lost her IV form. And remember, when this time occurs, when you don't have any IV form to give the magnesium sulfate, you just do the IM, because we can just inject magnesium sulfate in the buttock IM. So it can also be the emergent stabilized for seizure prevention. And also, when you already give her magnesium sulfate and the seizure goes away, then we should control the hypertension, that we said before, the labetalol or nifedipine or hydrolysine, and control the blood pressure, or the patient might go to the stroke in the end. So give her blood pressure control and also stabilize. And now is the time to deliver. When the patient have eclamptic attack, you should just deliver a baby, because if you don't deliver a baby, then the baby just might died because of the placenta rupture, or maybe the patient will occur another eclamptic attack again. So when you have the first eclamptic attack, I don't suggest you just to keep the pregnancy. I suggest you to just deliver a baby as soon as possible. And sometimes you can deliver it from vagina if the cervix is ripened, the mother is like multiparous and the baby is already coming out, then you can just do the vagina delivery. But if not, if it's like a very severe situation, eclamptic attack, and the patient is the first parent, then you just do an emergency cesarean section to let the baby out, so that the neonatal doctor can take care of the baby. And also, when the circulation comes back, we can make the mother recovery much better. Okay, so eclamptic attack, remember to keep the airways, vital signs, do the NGSO4, and to just deliver a baby and do the blood pressure control. And then we have to monitor the neurologic signs. So when you already have an eclamptic attack, when do you have to send the patient to do a CT scan, to do a CAT scan? Remember these things. If they have a focal neurologic deficit, like if they have like deformed limb numbness, or they cannot move their legs or their their arms, presence of focal neurologic deficit, or they're already in coma and a prolonged coma. Do not recover after delivery. They do not recover after the magnesium sulfate, or even your treatment level of magnesium sulfate already reached, but they still have a repeated seizure attack, then you should send them to do a cerebral image to see if they have a bleeding, blood clots, or stroke or hemorrhage in their brain. So, like my patients before, we also had a patient that sent from the ER already have eclamptic attack at home after delivery a baby. She also have to have the neurosurgeon operation to remove the blood clots in her brain. So, or the patient maybe have a blindness, or the onset is before 20 weeks, as we said before. If we onset before 20 weeks, then it might not because of the preeclampsia. It might not because of the eclampsia. It might be because of other pre-existing neurologic problems. So maybe like a brain tumor or other things. So if the onset is before 20 weeks, remember to do a cerebral image. Okay. And also if the onset is after 48 hours postpartumly, then you should also do the cerebral image to see if the patient have other pre-existing cerebral problems before. Okay, so in the end, we can see all the management is like a place of care, the consultation, fluid management, antihypertensive agents, and do the risk checkup, and give the magnesium sulfate, corticosteroid, and platelet transfusion if the HELP syndrome. And also, now we already deliver a baby, everything is smoothly, but sometimes the postpartum preeclampsia can occur after the baby's delivery. And especially when the patient she doesn't have any hypertension during her pregnancy care. Like if you have a very smooth delivery, uneventful, like the patient delivered her baby from vagina at 40 weeks of gestation, there's no blood pressure problem during the whole period. But the patient might develop a postpartum hypertension, a new onset one, uh, after delivery, and the of about 6 weeks postpartum, it can still occur. So, before delivery, but after postpartum 6 week, we still have to remember that you can have a hypertension, new onset hypertension, and you can also have all we said before the severe features like heart failure, like neurologic symptoms, like the liver enzyme, like the kidney disease, everything we said before, it can occur postpartum and also the proteinuria. So postpartum preeclampsia is might be because of many etiology, but of course it's still a placenta dysfunction. But maybe the toxins not resolved so well. So remember, 6 weeks after delivery, we still can have a postpartum preeclampsia. We have to observe a new onset hypertension. We have to check the urine protein to creatinine ratio. We have to remember all the warning signs because when this happens, we have to send a patient back to hospital. We have to have the magnesium sulfate again to do a seizure prevention. We have to monitor everything. The only thing difference is that we don't have the baby now, so we don't have to worry about the baby. We just have to check the mother herself. But also the postpartum preeclampsia can develop to postpartum eclampsia. So they might also have a seizure attack. So it's also very devastating. Okay, so all the management, like we said before, is before pregnancy, before 20 weeks, before 37 weeks, after 37 weeks, and even postpartum care. All this period when the woman is getting pregnant until late delivery, we have a lot of things to care about. So for a patient, she already have a gestational hypertension in this pregnancy. Futurely, when she had a future pregnancy, she had a risk of developing a gestational hypertension again. And for the future preeclampsia, the risk is still high, and she might have a cardiovascular disease in her future. And for preeclampsia patients, the risk of gestational hypertension in future pregnancy is very high, and also possibility of a future preeclampsia. And also, she might have a cardiovascular disease, and also maybe the proteinuria if she doesn't resolve after 6 weeks of postnatal, then she might have an end-stage kidney disease. We also had a patient that have to do a renal dialysis after delivery until till a very long time. So that preeclampsia can cause end-stage kidney disease after the women deliver a baby for a very long time, and also thrombocytopenia. And when they have a severe feature, then futurely, of course, you will develop preeclampsia certainly. But what we want is to postpone it. Maybe we wish like you can after 34 weeks, then it's not so severe. Okay, and also cardiovascular disease is for certain when this patient has a HELP syndrome or Preeclampsia or severe feature in this pregnancy. So life after preeclampsia or gestational hypertension, we have to remember you have a very high risk of all these things like blood pressure, like a diabetic, like stroke, um, 2 in 3 women will die from a cardiac disease. So it's like a long-term disease for this patient. They should take care of themselves. So adopt a healthy lifestyle for yourself and get a regular exercise, eat a well-balanced, healthy diet, maintain a healthy weight, stop smoking, and take any prescribed medication for your hypertension. And remember to speak like you already have a preeclampsia before to your obstetricians when you have a next pregnancy. And supposedly you should see the cardiovascular doctors for a regular checkup. Okay, so for the summary today, we have a patient. If you have patient in your clinic, you have to remember to see from the early gestational week, from 11 to 13 weeks, to identify do they have a high risk. If they already have a previous preeclampsia, then it's certainly a high risk. And if they do not have a high risk factors, we go to FMF to do a preeclampsia screening. And if they're high risk, remember to start bulky before 16 weeks of gestation. And then goes to 20 weeks, and we have to watch out. Do they have a blood pressure problem? Check blood pressure since 20 weeks every antenatal care. And supposedly, if they can do the home BP measurement, is the best. So if the systolic blood pressure more than 140 or diastolic more than 90, remember check the urine protein to creatinine ratio. And if you already have more than 0.3, you have elevated protein creatinine ratio, then you are preeclampsia. You can just diagnose it after 20 weeks. Okay, so if it's at 24 to 28 weeks, you can use the 71 pure GF factor to check if they can have a severe feature, the prediction. You can use like even above to 34 weeks. So if you're already over 38, remember to do the weekly antenatal care to check the BP, urine protein creatinine ratio, fetal umbilical flows, and consider timing of delivery. And if you are before 34 weeks, remember to get a corticosteroid to fetal lung maturation. And above this time, we have to watch out if the severe preeclampsia, we just do immediate admission and do a magnesium sulfate and stabilize the patient, consider delivery. And if you're a mild preeclampsia, then you can get a SOF2-1 screening to see if you can develop to severe severe feature in 2 weeks. So, and also do a fetal umbilical cord flow and get a corticosteroid and evaluate the timing of admission and delivery timing. And if you're already above 34 weeks, just consider timing of delivery. And if it's above 37 weeks, you don't need to worry so much. Just deliver a baby. Okay, and make sure that we remember postpartum till 6 weeks, we still observe the neurologic symptoms, the BP, and the warning signs. For the measurements for target blood pressure, we should control systolic blood pressure 130 to 140, diastolic to 80 to 90, and the medication of choice is labetalol. And for severe forms, then we should have the magnesium sulfate for seizure prevention. For eclampsia, still magnesium sulfate and delivery. Okay, so this is the final table. Remember, it's a placental disease. It's a placental disease. So its etiology is from the placenta. So it's preventable. It's a preventable disease. We have to remember this. It's a placental disease and it's preventable. So we identify the high risk group by using risk factors, by using screening. We give them aspirin for population, and we suggest them to do a lifestyle modification. We suggest them to check their BP and do the exercise. We can give them calcium and provide them vitamin D, and we should do a diet control to eat a healthy food. And then we check the urine protein when the blood pressure becomes higher. You can use a spot urine PCR or ACR, but I would suggest a PCR. But if you do not have that, you can have a dipstick or you can use a 24-hour urine protein. And we have to always remember the severe features. So you can use this to do the screening, but most important is that we acknowledge the severe features and deliver if the severe features occurs. And we have to now acknowledge that HELP syndrome and eclamptic management. And for medications in all these section, we only have to remember aspirin is for population, magnesium sulfate is for seizure prevention, corticosteroid is for fetal lung maturation, and for the antihypertensive agent, I would suggest labetalol as a first choice. Okay, thank you for listening. Uh, okay, thank you very much.
Thank you, Dr. Wang, for the insightful presentation. Now we will enter a question and answer session. We have like 10 minutes. So everyone, feel free to type your question on the chat box or raise your hand if you'd like to speak directly. We will try to address as many as time allows. Jadi rekan-rekan semua, peserta kegiatan webinar, saat ini kita memasuki sesi tanya jawab dengan Dr. Wang. Bagi yang ingin bertanya, bisa membuka mic atau bisa juga menuliskan pertanyaan di kolom chat yang tersedia. Jika terkendala dengan bahasa Inggris, kami akan siap membantu.
Uh, Excuse me, can you ask the question again?
No, I explained to them in Indonesia that
Okay.
we are right now we are in question and answer session. So if they have like difficulties in English, then I will gladly to help them.
Okay. Thank you.
Yes.
I have a question, Dr. Wang. Excuse me, can you
Yes.
hear my voice?
Yes,
Yes.
yes.
Yeah, thank you. Thanks in advance. I'm sorry, I'm not good in English, but can I ask in English?
Yes. Yes. It's okay.
Regarding the theory of preeclampsia, if there are signs of swollen legs, high tension, and positive urea. But what happens when labor suddenly show sign of HEP syndrome? Even though during pregnancy there are no signs of preeclampsia, what should be done? Thank you.
Uh, do you just ask if HELP syndrome without eclampsia?
Yeah,
So if you have a patient like have HELP syndrome but no eclampsia attack, what should we do? Is that your question?
yes, right.
Okay. Oh, okay. So HELP syndrome will develop to eclampsia. So no matter your preeclampsia or your HELP syndrome, in the end, you can develop to eclampsia. So for HELP syndrome and severe feature, we still do the magnesium sulfate. You have to admit, like the patient, live to your hospital. You have to admission the patient. She has to be admission and she has to have the magnesium sulfate to prevent the seizure prevention because all these hypertension disease in the end they will develop eclampsia. So just give the magnesium sulfate. And you have to decide the gestational weeks and decide when you deliver the baby. And if you have a difficulty in decide decision, you just see if the patient is in a severe signs, like it's already dyspnea, like all the or lab testing is not good. Just deliver a baby. You don't really need to hesitate too much because when you hesitate to deliver a baby, then the patient might just have a eclamptic attack, even if you use the magnesium sulfate.
Thanks, Mr. Wang.
Dr. Wang, there is another question in the chat box. Given that the early detection of preeclampsia often remains a challenge, are there new invasion biomarkers or a combination of biomarkers that show higher accuracy and specificity compared to the conventional screening method? And what is their potential for in implementation in developing countries with limited resources like Indonesia?
Okay. So like I showed in the PowerPoint before, if in the first trimester you can use the FMF, they will use the PLGF factor to do a checkup. And but if it's like a second or third trimester, it's a SOFT1 and the PLGF ratio to detect to screening if they have a high risk. But it depends on each country. Like in Taiwan, it comes into Taiwan like 2 years ago. It's not still very common in Taiwan, but I'm sure like in Indonesia, in your country, you must have some company, like biomarker companies, they will do a SOFT1 screening. Yeah, so you have to reach out to see which company they do have this kind of screening method, and you have to contact with them to see if your hospital can adopt this screening method. It could be useful. But sometimes the disease is very challenging because it can be very mild, like she doesn't have anything, uh, and then just delivery, just have hypertension. But it can be very abrupt. You can just suddenly onset. So if we do have use the marker, it's helpful. But in Taiwan, not many people use this SOP1 marker as well because it's very expensive. Like do it once here in Taiwan, you have to cost like 4,000 Taiwanese dollars. And in Taiwan, it's a very big money for the prenatal care. So not many people do that now. And especially when the soft T1 marker, they can only predict for 2 weeks. So after 2 weeks, if you found out that she need to do it again, she have to spend another 4,000 Taiwanese dollars. So it's actually also very expensive for most of the patients in Taiwan. So it's not that common here. So if you ask me for the best solution for all this, I think I'll just use the risk factors. Like you have the checkups, and if you found out that patients is already high risk, you can just give them the population aspirin, and then you have to uh very curious, very careful. Like if your patient already have the preeclampsia before, then I will let her to have a checkup even 2 weeks every antenatal care. So by the visit, you can check the blood pressure. You can have very strict strategy. Like if your blood pressure is over 130, then you can just start to monitor at home. And also the urine protein to creatinine ratio. I think you must have it in Indonesia because it's not a very expensive screening and it's not very uncommon. So you can ask your hospital or familiar systems, do they have the urine protein to creatinine ratio? Because it's very accurate and it's very good way to detect the early urine protein. So when my patient have an early urine protein, I will ask them to come more often. So when they come back more often, we can do the ultrasound to check the baby to see if the baby growth is good or not, and these are all the methods that we can use.
Okay, thank you. Dr. Wang, there is another last question in chat box, but I will translate it into English. So this question is from Miss Indah Devi Pertiwi. She would like to know after the childbirth, is the preeclampsia is like finished or is there long-term health risk?
Uh, Normally, when the baby comes out and the placenta comes out, we can think like it's the toxins already comes out. I think everyone is familiar with the pus. Like you have a pus in your body, then we have to do a debridement, and after debridement, you also have to use the antibiotics. So it's the same idea as magnesium sulfate. So when the baby comes out and the placenta comes out, and supposedly the toxins already resolved, but still it's not just resolved immediately. It will resolve gradually, like you have to expel it from your body. So we will use the magnesium sulfate 24 hours after baby is delivered. We have to remember that. But if it's very severe, then you can consider to use it for 48 hours. And for what I said before, the postpartum new onset preeclampsia is not that common, but we have to just remember to tell all our delivery women that they have to remember to check themselves to see if they have a headache, if they have a nausea vomiting after delivery of baby, if they have upper abdominal pain, or they have any other discomfort when they deliver the baby. Like maybe they will have a visual disturbance, like maybe already deliver a baby for 2 weeks or 3 weeks after delivery, they can still have all these symptoms. Then it's not right. Then they should just check their blood pressure or just come to the clinic to see if they have a postpartum preeclampsia. So supposedly when you deliver the baby, then it's a final cure. But sometimes because everybody's situation is different, so sometimes it might occur postpartum. So we should still be careful. The end of that is 6 weeks of postpartum because we think after 6 weeks is the end of peripartum status, is end of the pure period. So supposedly your body will become go back to the natural process. You don't have to be worried about all the preeclampsia, prenatal or postnatal things. So remember to check up at 6 weeks postpartum. When the women come to your clinic with a normal blood pressure and everything's well, then you don't need to worry about it.
Thank you, Dr. Wang. That's like quite very good explanation. I hope everyone understand that after the child bite, then the preeclampsia is done, but you have to monitor yourself because everyone is different.
Yes, yes.
So there is a last question. Sorry, there is another question in chat box. So sorry. There is another last question in the chat box. In cases of pregnant women who have experienced preeclampsia in a previous pregnancy and then pregnant again, is there any technology to monitor blood pressure automatically and that can be attached to the mother body?
Excuse me, can you say the last sentence again?
Or is there any technology to monitor blood pressure automatically that can be attached to the mother body?
You mean a machine like attached to the body to check the blood pressure?
Yes.
Oh, okay. Yeah, we don't have that in Taiwan.
Okay.
I know the sugar. We have a sugar testing thing you can attach to your arm to test the sugar, but the blood pressure, no. Maybe some watches, like Apple watches, they can do this, but normally they just measure their heart rate and the capillary resistance. So no, we don't really have like the continuous monitoring of blood pressure machine yet. So we don't do it in Taiwan either. Or we just ask the patients to buy their own blood pressure machine at home. So if they're okay to do that, I will ask them to check their blood pressure early in the morning and late in the night before they go to sleep. And if the blood pressure is high, then maybe they will have to measure like 4 times per day by themselves. We just do the BP measure by the regular machine. Yeah, we don't have the very fancy machine now. As far as I know, there's nothing invented so far in the world, and I wish I can invent that in the future. Thank you.
Okay, thank you, Dr. Wang. So there is no that automatically mentioned, but we can like manually check a few times a day like that, did I?
Yes.
And there is one last question from Miss Tia Setiowiranti. She asks, before the pregnancy, there is no preeclampsia symptoms, but after when pregnant, there is a preeclampsia and there is no family history with a preeclampsia. So she would like to ask, will there in the next pregnancy, will there high risk pregnancy or no?
Yes, yes, of course. You mean like the patient had no hypertension before, but she had preeclampsia this
Y-
time, right? So
Yes.
the next pregnancy, she already high risk.
Okay.
Yeah, so in my clinic, when I have a mother like first time and she had preeclampsia, I would tell them to remember to take aspirin when they get pregnant next time. I would just let them remember this is very important for their next pregnancy. She's already a high risk group.
Actually, this is related to the previous question that if the pregnancy have preeclampsia, how to minimize the next pregnancy preeclampsia, and the answer is aspirin, right?
Yeah, yeah, the answer is aspirin. And
Okay.
also, you can take the calcium and also take the vitamin D and also do exercise. So, if a patient have a preeclampsia in the first pregnancy, also we can look back to this patient. If like she's a little bit obesity or very obesity, then we can suggest her to do the lifestyle modification for the next pregnancy. Like maybe she's 100 kilogram now, we can suggest her to lose her body weight to like 70. So next pregnancy, she might be more healthy. So the preeclampsia is not just only the aspirin for the population is also before pregnancy, you can do a lot of things to make your body healthier. So you can reduce all the stress in your body, and maybe next time, along with aspirin, along with a better body, then you can have less incidence of preeclampsia attack.
Okay, thank you, Dr. Wang. I would like to extend my sincere gratitude to our Dr. Wang,
Thank you.
who already have the insightful presentation and valuable discussion. Your expertise has provided us with important perspective on how we can improve maternal health outcome through early detection, effective management, and preventive strategies. Thank you, Dr.
Thank
Wang.
you. Thank you very
Uh,
much.
yeah, we would like to present you a little bit of our heart. However, due to our different location, for now we would like to symbolitically, virtually giving you our
Thank you.
souvenir. So we
Thank you
would like
very
to take,
much.
yes, after this webinar, our committee will send it to your address.
Ah,
Thank you.
thank you. Thank you very much. The photo will be enough. Terima kasih.
Yeah, sama-sama. Everyone, please give applause to Dr. Wang.
Thank you.
Yes, thank you, Dr. Wang.
Thank you. Bye bye.
Bye bye.